Okay, good afternoon. It looks like we have everyone. So we'll resume the Green Mountain Care Board's hearing of December 6th, and we'll turn to the Medicare only ACOs and Ms. Sawyer for the presentation.
Great. Thank you, Chair Foster. I am joined today by our staff attorney, Russ McCracken, to present a few slides as well. The agenda for this afternoon, just touch briefly on the scope of review, and then we'll look at Loar Health's budget. We'll review the public comment that we have received, staff recommendations, and the potential motion language. And then we'll go right into a review of Vitalize Health 9. We have received some additional information that we want to review with you all. We want to touch on the public comment. We'll review some staff recommendations, and there will be time for board discussion, potential motion language, and of course, at the end, we welcome public comment. So the scope for Medicare only ACO reviews, they are not subject to certification in Vermont. Smaller ACOs are under a different section of the statute. Loar Health and Vitalize Health 9 have less than 10,000 lives in Vermont. And in previous presentations, we've gone more in depth into what the statute says. So this is just a brief reminder. Both of these ACOs are participating in standard Medicare models with terms that are established under federal rule. And both of these ACOs are multi-state ACOs. So we will start with Loar Health and their FY24 budget. So to date, a single public comment has been received, and it is from the Office of the Healthcare Advocate. They wanted to share some of their concerns. They include lack of evidence regarding the efficacy of the model of care, a lack of transparency, and their profit priority motive. Recommendations from the Office of the Healthcare Advocate include that the board require Loar to submit financial and quality reporting to the board annually, for the board to establish a deadline for confidentiality requests in the budget guidance, and that the board should expand the scope of authority over Medicare only ACOs. So here are some updated staff recommendations. These are very similar to the ones that we reviewed previously. The text in red is just some updated language, tightening some things up, but the intent remains the same behind these recommendations all in all. So I'll talk through them. Recommendation number 1, Loar Health provides to the Green Mountain Care Board its shared savings and losses segmented for Vermont. This is a carryover from FY23. Recommendation number 2, Loar Health provides an updated version of their Vermont financial summary. The GMCB staff would develop that template and set a deadline. Recommendation number 3, Loar Health provides to the Green Mountain Care Board its Medicare Shared Savings Program quality reporting segmented for Vermont, if possible, with appropriate restrictions to protect patient confidentiality. Recommendation number 4, following 3 performance years in Vermont, Loar Health provides reporting for those years on GMCB specified metrics, which may include the categories of inpatient medical, inpatient surgical, emergency department, professional office visits, ambulatory care sensitive admissions, and any additional metrics. The GMCB staff would develop the template and metrics and set a deadline. Recommendation number 5, Loar Health provides a semi-annual update about how Loar Health's care model is working in Vermont, including any consumer complaints received from attributed Vermont beneficiaries. The board staff would develop this template. And the final recommendation is that a representative from Loar Health must engage in an orientation led by the Blueprint for Health within the first quarter of 2024. And just a note on that final recommendation, there had been a question during the last time this topic came before the board about the availability of these orientations from the Blueprint for Health. And I did touch base with them, and they are happy to engage with any ACO that would like an orientation on their program. So the suggested motion language for LOR is here. Move that the GMCB approve LOR Health's ACO's FY24 budget as submitted to the board, subject to the conditions reviewed by the board today. So we're going to scoot right along into Vitalize Health 9 ACO. We have received, as of December 5th at noon, which was yesterday at noon, 58 public comments. The public comment period ran from November 1st through December 5th at noon. We did extend that public comment period for several additional days following feedback from the public that they wanted more time to have their voices heard. So the board welcomes these comments. We encourage the public to engage in its processes. And so here are some of the themes that we heard. There's concern around the private equity firms and for-profit motive, the concerns around privatization of Medicare, concerns surrounding potential effects on healthcare delivery. There was, as I mentioned, a concern that the public comment period was too short, and some public comments around how the board should reject Vitalize budget or delay the vote. Little Rivers FQHC, which is one of the participating providers in Vitalize's network, did submit public comment. They said that they wish to engage with value-based care arrangements and did explore several ACOs. The ACO agreement does allow for disengagement with the ACO at any time, and that they are they have signed up to be a part of Vitalize Health as a way to ensure their financial health of their practice. The Office of the Healthcare Advocate also submitted public comment. They voiced concerns about the motives of private equity firms or for-profit. They are skeptical that Medicare-only ACOs, whether they create savings or reduce spending. They're concerned about the efficacy of the model of care, and they're concerned about the Vitalize potentially being a competitor to OneCare Vermont. They gave the board a set of recommendations that Vitalize Health 9 to submit financial and quality reporting to the Green Mountain Care Board annually, establish deadlines for confidentiality requests and budget guidance, and that the Green Mountain Care Board should expand the scope of authority over Medicare-only ACOs. I wanted to just review a little bit of new information that we've received from Vitalize since we spoke about them last. They had some follow-up items that they were going to provide for us, one of them being a chart, an organizational chart. So all the ACOs on the chart are owned in full by Vitalize Health LLC, except for Physician Leaders, which is an ACO, which Vitalize Health has an investment and operate under a management services agreement. But you can see that they have Vitalize Health 9, as well as several other ACOs under different federal models. An update regarding their health equity plan. During the hearing, it was stated that Vitalize Health 9's health equity plan would roll out nationwide in 2024. The ACO provided an update stating that while CMS has approved the plan, in the start of 2024, the initiative will actually be implemented in a single zip code in Mississippi, and not nationwide. So if the program is deemed successful, it could be expanded into additional regions. And then they shared some example goals around their health equity plan, which has to do with food insecurity. The goals for this initiative include no increase in ED visits and inpatient admissions related to complications from food-related chronic illnesses. They also provided an update to who is included in this provider network. They listed 52 providers were included, and we were curious about what types of providers were in that count. So we have primary care physicians, nurse practitioners, physician assistants, obstetrician gynecologists, certified nurse midwives, clinical social workers, psychiatrists, and dentists were included in that count. And then we'd asked them a question about how their quality withhold was handled. And they stated that it exists, it is not considered until their final shared savings numbers are received. They are not baked into those PMPM payments that are going to providers. So they really don't even consider that quality withhold until they're after the end of the program year. Of all the support payments made to providers, the priority care program support payments are the only ones not considered an advance in shared savings. I also wanted to touch on some key points, especially because there's so much public interest in Vitalize Health 9. So I wanted to draw some distinctions between Medicare ACOs and Medicare Advantage. A Medicare ACO is different from Medicare Advantage. Medicare Advantage is an insurance product, and those who choose a Medicare Advantage plan are no longer enrolled in traditional Medicare. The Medicare Advantage company processes, adjudicates, and pays claims. Rightfully so, many are wary of Medicare Advantage plans. And in the case of a Medicare ACO, the ACO works with the provider and with Medicare. A patient is still a beneficiary of traditional Medicare. And even though the funds flow between the way that the funds flow between CMS and the ACO and the provider may change, all claims will be processed, adjudicated, and paid by CMS completely outside of the ACO. The ACO itself does not have the ability to deny claims. I also wanted to mention that the ACO REACH program is a type of Medicare-only ACO that replaced the global and professional direct contracting model. This program, of which Vitalize Health is a participant, is intended to be an improvement upon the previous GPDC model. There have been some valid concerns about participants in that previous model, known as direct contracting entities. And in order to address these concerns, CMS worked to make the following improvements to the ACO REACH model. So 75% of the governing body of a model participant in the ACO REACH must be made up of participating providers, whereas in the previous model, that requirement was only 25%. This means that in the ACO REACH, that on-the-ground providers are steering the ship for the ACO rather than stakeholders who may have any sort of motive. An ACO REACH entity must also have a consumer advocate and a beneficiary, both with voting rights on their governing body, and the previous model did not have this requirement. CMS also responded to concerns of patient risk coding abuse by changing from a cap on risk score growth of 3% a year over year in the previous model to a 3% cap from a static base year, meaning that if the underlying demographics of an ACO do not change, risk scores can never grow more than 3% during the model performance period. Also, CMS stated that they are prioritizing increased vetting of applicants to the ACO REACH model in comparison with other CMS ACO models, and has increased ongoing monitoring of model participants as well. CMS is monitoring model participants in the following ways. They monitor levels of care They monitor levels of care provided to make sure that the ACOs aren't skimping on beneficiary care. CMS conducts compliance audits throughout the year, investigating beneficiary complaints, and conducts beneficiary experience surveys, the CAP surveys, annually to ensure there isn't a change in beneficiary satisfaction. They also monitor whether or not beneficiaries aligned to the ACO are being moved out of traditional Medicare and into Medicare Advantage. I'm going to pass it over to Russ for this slide to walk us through a couple additional points, including the Green Mountain Care Board's process in reviewing these budgets.
Thanks, Michelle. So just a couple of further points to kind of round out what Michelle was saying, and then I'll talk about the board's authority. The first is under the REACH model, beneficiaries have the option of opting out of the data sharing. So CMS may share aggregated claims data about financial performance and quality for an ACO, and beneficiaries can call CMS and opt out of that, having their claims data shared in that way. Just to make the point clearly, an ACO enters the market through finding providers who want to participate with that ACO. It's not a decision the ACO can make on its own. It's a joint agreement with a provider, and it's voluntary for the provider, and it is usually done on a year-to-year basis, so the provider could back out depending on how the provider's experience with the ACO goes. So a couple of things about what the board's authority is in this particular space relative to ACOs that have contracts only with Medicare, and in these cases, there are also ACOs with fewer than 10,000 attributed lives in the state. So it's very explicit in the statute that ACOs that only have Medicare contracts are not required to be certified by the board. Under Section 9382A, certification is only required for an ACO to receive Medicaid funds or commercial funds. So what we're left with here is the budget review, where, as we look at the statute and the rule, the board is tasked with reviewing, modifying, and approving budgets, which is unlike the certification where the board may either approve, provisionally approve with conditions, or deny a certification application. So under the current statute and rule, the board does not have authority to prevent a Medicare-only ACO from entering into the state. The authority for the board to prevent an ACO from operating in Vermont falls under the certification provision, which explicitly isn't required for the Medicare-only ACOs. I'd also note this is consistent with the enforcement provisions in the board's ACO oversight rule. Those enforcement provisions set remedial actions that ultimately could culminate in the revocation of certification. So if we think about the kind of ultimate enforcement as stopping an ACO from participating or operating in the state, the rule sets that up, that ability to stop the ACO from operating in the state as revoking the ACO's certification. I also want to note here, as the board considers the budgets of these ACOs, there are quite a few programmatic elements of the REACH model or the MSSP model, depending on which ACO we're looking at, that are set by CMS. And those are elements that are outside of the board's authority to change. Their provisions that are determined by CMS in its rules and regulations. So, making a similar point to that, the board is regulating the ACO conduct in Vermont. We're not regulating an ACO's operations in other states. So what we're left with here is using the budget modification authority and some broad kind of reporting authority that the board has under the ACO oversight rule to require reporting and regulation, reporting and so monitoring provisions of ACOs. And based on that authority, we've crafted some staff recommendations that Michelle is going to walk through which are sort of designed to help the board monitor the financial and quality performance and results of the ACO in the state. So Michelle, I will turn it back to you, I think.
Thank you. So I already spoke verbally to some of the safeguards that CMS has in place, but this slide has them here in writing if anybody would like to refer back to this. So here are some updated staff recommendations for Vitalize Health. They may seem a little familiar. So recommendation 1, Vitalize Health 9 provides the Green Mountain Care Board its shared savings and losses segmented for Vermont. Recommendation 2, Vitalize Health provides an updated version of their Vermont financial summary. GMCB staff to develop the template and set the deadline. Recommendation 3, Vitalize Health 9 provides the Green Mountain Care Board its ACO REACH quality reporting segmented for Vermont if possible, with appropriate restrictions to protect patient confidentiality. Recommendation 4, following 3 performance years in Vermont, Vitalize Health 9 provides reporting for those years on GMCB specified metrics, which may include the categories of inpatient medical, inpatient surgical, emergency department, professional office visits, ambulatory care sensitive admissions, and any other additional metrics. GMCB staff to develop the template and metrics and set a deadline. Recommendation 5. Vitalize Health 9 provides a semi-annual update, the first report submitted with their FY25 budget submission on October 1st, 2024, about how Vitalize Health 9's care model is working in Vermont, including any consumer complaints received from attributive Vermont beneficiaries. GMCB staff to develop the template. And the final recommendation, a representative from Vitalize Health 9 must engage in an orientation led by the Blueprint for Health within the first quarter of 2024. Here I have some suggested motion language. Move that the GMCB approve Vitalize Health 9 ACO's FY24 budget as submitted to the board, subject to the conditions reviewed by the board today. And at this point, I will turn it back to you, Chair Foster.
Thank you both very much. I'll open it up to the board members for question and comment, and then we can see if anyone wants to make either of the motions, but I guess we'll take some board member discussion first or questions if there are any.
Let me just ask one question. On recommendation 5 for both of the Medicare only ACOs, I'm wondering if there's any value in expanding the gathering of information about consumer complaints beyond just Vermont. So asking for all consumer complaints, not just those in Vermont, just to the degree that we can learn from what's happening in other states with these ACOs. So just a question for the staff on that one.
I don't see any obvious obstacles to expanding that recommendation to include consumer complaints from their network of national beneficiaries. I don't see a problem there.
Ms. Sawyer, one, which is, are we aware, are there any investigations or litigations or any sort of findings of any problems with either of these ACOs to our knowledge?
Not to our knowledge, no.
I have a comment that really is a reflection on reading a lot of the public comments, which is I hear the real concern of profiteering in healthcare delivery. And I'm very profoundly bothered by aggressive business tactics, whether it be for-profit or nonprofit within healthcare. But this is challenged because I really do believe that really the soul of this may sound a little tacky, but I'm honest with it, that I believe the soul of medicine is the art of medicine, and that real artful practice of medicine is most exemplified by the primary care patient-provider relationship, where there's trust, where there's understanding, where there's comfort in having that relationship over time. And I'm a firm believer that really helps people live healthier, it helps people live happier. I think it probably reduces the cost of care, reduces unnecessary testing. I think there's literature to support that. So I guess my bigger concern with primary care is the opportunity to have that relationship as being eroded by the challenges that are facing providers of primary care and patients accessing primary care, whether it be through the burdens on primary care providers through prior authorization or compliance or reimbursements that are just really not keeping pace with the cost of delivering primary care. So I hope that the ACOs that are the primary care providers, the practices, the FQHCs that are joining these various ACOs are doing so. I think they're doing so because they need the financial support to continue to provide high quality healthcare to their communities. And I understand the frustration of that, that there's profit going away from Vermont to these organizations. But at the same time, it appears to me that the Vermont organizations are benefiting substantially with their mission of trying to deliver their care they're delivering. So that's just my general comment on these ACOs. Thank you.
Yeah, this is Tom, and
Go ahead, Todd.
thank you. I wanted to just briefly echo Dr. Merman. The thing that struck me most from the numerous several dozen public comments we got were the frustrations with not even profiteering per se, but a focus on finance over people, and how frustrating that is for Vermonters, and how much stress that adds. Some of the concerns that were raised caused me to really reflect on my understanding of what the ACO REACH model does. And so I double and triple checked, and I want to thank Michelle and her staff for double and triple checking. This new model seeks to address many of the concerns of past models, and specifically limiting networks, upcoding, cherry picking, governance by administrators. The REACH model specifically addresses those and really tries to take the features that have worked with ACOs, that have worked. Those include keeping it small, keeping it focused, and having it be provider-led. And providers in Vermont have selected to join these ACOs because they think it will help them care for their patients. So I think that's important for us to reflect on. It's also important for us on the board to read the comments and hear the frustration in our community. And I did, and I want to acknowledge that I read them and I heard it.
I don't have anything else to add that others haven't already said. I do think the recommendations do a good job of staying within our scope, admittedly limited though it be, and ensuring transparency and monitoring. So I appreciate all the work, Michelle and Russ, that you've put into it. Thanks.
Could you put up the motion language again, Ms. Sawyer, if you can?
Would you prefer the one for lore or the one for vitalize?
Vitalize, I guess, since we're here and close
Okay.
to it. Oh, Mr.
Sorry,
McCracken?
This is a quick thing. I just wanted to note Member Holmes' change in one of the conditions. So the motion language would be changed slightly to say something along the lines of conditions reviewed by the board today with those changes discussed by the board today. So we can make
Yes.
Member Holmes change in the final version.
Yep, great, thanks. And I agreed with Member Holmes's change, and I think that makes sense to broaden that. So I'll move that the GMCB approve Vitalize Health 9 ACO's fiscal year 24 budget as submitted to the board, subject to the conditions reviewed by the board today and as modified by Member Holmes's suggestion.
I'll second.
Did we lose the chair? He looks
Oh,
frozen.
I'm still here. I didn't hear a second though.
Oh, Tom seconded.
Oh, okay. I might have glitched out for a second. Okay, great. Well, so we have a second. Thank you very much. We can go through any board comments on the motions. I'm not sure there will be much. I will just thank Michelle and Russ for walking us through and reminding us of where our authorities lie and the context of this review. So with that, is there any other board comment or discussion on the motion? Okay. Hearing none, I'll turn to the HCA as to whether or not they have any additional comment.
Yeah, thanks, Chair Foster. Just a brief one. Also wanted to reiterate and thank everyone that submitted public comments. It's probably no surprise that we think this engagement is important and helpful. I also want to thank Michelle and Russ. We agree with the staff recommendations and also with Member Holmes' suggestion. I think that's a good one. And we also agree with the board's analysis that currently at present, the board doesn't have the power to deny a Medicare-only ACO from operating in the state. I think for us, what that unfortunately presents the board is a dynamic of essentially voluntary compliance with regulation by these entities. I mean, I think what we worry about is these well thought out recommendations. Entities like Lore or Vitalize could simply choose to not comply with them. And I think the board's lack of authority is something that the board could address through a rulemaking process that we outlined in our comment. So thank you.
Great, thank you. And I'll open up to public comment. Ms. Wasserman.
Yes, thank you. Julie Wasserman here. I guess my comment is more overarching. I concur with all of HCA's thoughts and comments. I guess my one comment would be that we've got problems in Vermont when FQHCs need to resort to this model. And I think that this discussion and the actions point to some serious problems in terms of the way Vermont treats primary care. And I'm hoping the Green Mountain Care Board maybe in the future can address some of these issues so that other FQHCs and other primary care practices, independent ones, won't be forced or have to resort to a for-profit model just to maintain their existence. Thank you.
Thank you. Walter, I saw you come on camera. Did you have a comment?
Hey, Owen.
Hey.
A couple. To your question about litigation with Vitalize, Dr. Marvin Malik sent in a commentary that I read. I read those public comments too about the history of the founders of Vitalize, which was really pretty telling about their motives. I agree with the ACA that these people can just skirt regulations or recommendations, whenever they want to. And I agree with Julie on her comments about the private motives of the private firms and the state of primary care. And I also want to back up what Dave said about the relationships. As a patient, it's always strained about, because these private companies are coming in, calling you, trying to manage your care and then billing it to Medicare. And then you wind up getting billed yourself for something you didn't know about, because it's all about the money right now. It really isn't anything about the patient per se anymore. It's how much the patient is a source of revenue. And I don't see, I wish the board did have the authority to knock back Vitalize or Lore, because I don't see them doing anything really for us except siphoning out our dollars. But I did want to back Dave up on that comment, because as a patient, it's really hard right now.
Great. Thank you, Walter. Mr. Barter, and I'll just try to introduce people from where they're affiliated with, and I believe you're the CEO of Little Rivers. Please go ahead.
Thank you, Chair Foster. That's correct. I wanted to thank the Care Board and all those that participated in the public comments. We appreciate what's been discussed, and we hear the concerns in the public comments. They're helpful for us as we find our way. I also want to reassure that no external entity will intervene with patient-centered care here, directed by our providers solely. That will never change, and we hold to that. I also wanted to give just a quick story on how we got here in terms of our health center. I could give a long story, a short one with respect to everyone's time. Our understanding historically has been that our particular health center, due to geography and the health service areas, may not be ideally or practically aligned with programming at OneCare. And so we ended up in a situation where we haven't been a participant in value-based care transformation and with OneCare Vermont, and haven't had that component of to help us with quality and also with sources of revenue that come with that. And so we did engage with setup activities with Vitalize this year in anticipation of participation some or all of next year. Our engagement, it may be termed at any time. I think we're both presumably motivated to follow the morals and the ethics of Little Rivers Healthcare, but if by any reason we deviate from that, then we will discontinue our participation. I also want to share that we have engaged directly with Green Mountain Care Board in some conversations and anticipate continuing on that path. And we have met with A. Berman and Carrie Wolfman from One Care Vermont, and we're very hopeful to. It's our understanding that the Comprehensive Payment Reform Program may be extending from private practices to FQHCs in the course of 2024. So I just wanted everyone to know that we're thankful for all the conversation. We're committed to our patients. We want to be part of the movement in Vermont with Vermonters, and that's it. Thank you.
Thank you very much, and thank you for providing the public comment to give the board a little more information. And thank you for all the public comment that we did receive. It was well done and informative, and made the board really look hard at this. So thank you. Any other public comment? Okay. We have a motion. It's been seconded. All those in favor, please say aye.
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 Aye. And the motion carries unanimously. Ms. Sawyer, would you mind pulling up the staff recommendation for LOR real quick, and then we can go to the motion language. Okay. Member Holmes, would you want to expand number 5 as to these recommendations as well?
Yes, please.
Okay. Okay. If you could pull up the motion, please. I move that the Green Mountain Care Board approve Lower Health ACO's fiscal year 24 budget as submitted to the board, subject to the conditions reviewed by the board today and as modified by Member Holmes.
Second.
And is there any board discussion? Does the healthcare advocate have any comment on the Lower Health motion?
Nothing else. Thank you.
And is there any public comment? All those in favor of the motion, please say aye.
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 Aye. And the motion carries unanimously. I think that's all we had on the agenda today. So I'll ask whether there's any new or old business to come before the board. And a big thank you to our staff who really worked extra hours the last month and really last week on these presentations to provide the board a lot of information and a lot of things to think about and consider as we evaluate the One Care budget going forward. I appreciate that very, very much. And I thought the presentations were very, very helpful to frame our thinking as we move towards the vote and deliberations. Seeing there's no new or old business, is there a motion to adjourn?
Yes, I move to adjourn.
I will second it. And all those in favor, please say aye.
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 Aye. Motion carries and we are adjourned. Thank you and have a good afternoon.